Today we're going to talk a little bit about advanced care planning, kind of do an introduction. We're going to talk about some end-of-life planning tools, billing for advanced care planning, as well as a few examples. So to start with, what is advanced care planning? It's a face-to-face service between a physician or other qualified healthcare professional where you're going to talk about advanced directives and other kind of pertinent end-of-life information. Now, it's not necessary to sign or complete an advance directive, but it is important to make sure that it's brought up and discussed. It can be done at any time. There's actually no limitations to the location, frequency, or the type of provider that can bill for advanced care planning. It is typically recommended to be done once a year with an annual wellness visit, but that's not the hard and fast rule. And advanced care planning has been shown to be an ACO best practice because it's one of the best ways to reduce end-of-life total costs and unnecessary admissions by having those end-of-life discussions a little bit sooner or a little bit earlier than they may otherwise have occurred. Now, there's two codes that are going to be used with advanced care planning. The first, and definitely the most common, is a 99497. Now, that's for the first 30 minutes of the encounter, and it's actually for minutes 16 through 45. And then if a discussion happens to go a little bit longer and it reaches the 46-minute mark, then you would use an additional 99498 code to bill for both of them. That 99497 is typically reimbursed at around $85, and 99498 is typically reimbursed around $75. Advanced care planning does require discussion of an advance directive. An advance directive is a written instruction such as a living will or durable power of attorney for healthcare that's recognized by state law relating to healthcare when the individual is incapacitated. It's sort of that planning for end of life. And it gives the adults the opportunity to express in advance what they would like to see happen or the steps they would like to see their medical care team take. Now, the most common are going to be living will and durable power of attorney. We're going to talk about those two as well as a few others that you may see. Living will is really the oldest and the one that we typically think about the most. It's often what we start to think about as that do not resuscitate type level of care. But it's a signed or notarized document that's really the declaration or directive for what we would like to see happen to us towards the end of our life. Now, it's important that we're having these discussions, or if a living will is completed, that we're discussing it with family members so that they don't feel maybe thrown off or alarmed if there's something that comes up in the advance directive or that living will is different than what we would have expected. Slightly different but similar is going to be the power of attorney. So that durable medical power of attorney or durable power of attorney for healthcare is that identifying who should be making the decisions on your behalf or on the patient's behalf should they happen to reach a terminal condition. Now, you don't necessarily have to reach a terminal condition to have a durable power of healthcare attorney appointed. Similar to how you might sign up for life insurance even though you're not close to the end of your life, this is a great thing to start to identify, and again opens the door to conversations related to what would we like to see happen to us and involving those loved ones in those discussions. It's important that you feel comfortable with this as well as the signers feel comfortable with it as well. Similar but a little bit different, and you'll see these state by state being a little bit different, is the physician's orders for life-sustaining treatment, or sometimes called medical orders for scope of treatment. Now, these are standardized, portable, single-page documents that actually function almost like an order. And it's meant to be, this is the document that sort of flows with you wherever you go for care. Now, Utah has a specific physician's order for life-sustaining treatment, and on the bottom of this page we have a link to that tool. In Utah, the specific pulsed form is actually white. I've worked with other states where ours was a bright green, but this is a tool that you can fill out maybe as part of that annual wellness visit where you're doing advanced care planning. Maybe the discussion starts with a physician and ends with a clinical team member that is supporting filling out this pulsed form, where you might have a stack of them printed out or the website bookmarked so that you can easily go to it. And this is a document that the patient can take and sort of go with them to other specialists or other appointments. Now, having this form filled out and brought to other appointments can be a great way to make sure that other co-treating providers are on the same page. I'm a big fan of the Utah Life with Dignity order, and using this as your way to interact with other caregivers to ensure that they're providing the patient the care that they're expecting. Now, with advanced care planning, because it is a timed code, it's one of those that we have to make sure that not only are we discussing the advanced directive, but we are filling the minimum time requirements. So a couple other topics that are always recommended to discuss are patient's values, overall goals for treatment, palliative care disease-directed options. So that's if something goes worse, what are care alternatives? For some patients, they may need tips on ways to avoid readmissions, including including hospice care. Care preferences that the patient may have should something else happen, or even if it's not that full durable power of attorney for healthcare, discussions of who could be a surrogate decision maker if the time comes, and those could be leading to the next steps. And this is not necessarily a complete list or a checklist of things you need to do, but these are great topics to bring up. Advanced care planning is one of those that it's the right time for the right patient to have the conversation, and you start to feel more comfortable with the needs of the patient as well as your personal style the more conversations you'll have. A few tips on coding for advanced care planning is there's 2 specific codes, and they're meant to be kind of building off of each other, but not using interchangeably. So it's not quite like the transitional care management visit where it's one or the other. This is if you have a conversation that would qualify for that first bucket, meaning the first 30 minutes, it would be the 99497. And that's discussion of advanced directives. Whether or not you fill it out, you just have to discuss it by the healthcare team members or end-of-life care. And if you pass that 30 minutes and then you start to qualify for the second 30 minutes, you'd use the 99498 code. Now, both of these are valuable, but they do have some time restrictions to them. So advanced care planning is a truly timed code. While other E&M codes have time suggestions, this is a truly timed code. But just because it says 30 minutes, that doesn't mean you have to spend the full 30 minutes, or the physician has to spend the full 30 minutes with the patient to bill for the 99497. For instance, it just has to pass the midpoint of the time requirement. So the midpoint would be 15 minutes, so we would start to think about has to be at least 16 minutes in order to meet that midpoint. Now, this is the typical CPT interpretation from Medicare for CMS. You may want to check with your other payers just to see what their requirements are in terms of billing a timed code, but this is the typical requirement for Medicare. And it's about total effort by the clinical team. So if the physician starts the conversation and then hands it off to another team member to finish, that's okay. The time by both team members would count. Oops. The kind of insights on that timing is, so it has to be at least 16 minutes, meaning that if the conversation goes 14 minutes, it might be something that could add to the complexity of an already existing E&M to turn a 99213 into a 99214, but not necessarily a separate billable code. Once you reach that minute 16, you can bill for the 99497. And if you reach minute 46, you'll actually bill for both a 99497 and a 99498. If it would happen to reach minute 76, you could bill for a second 99498. Just a reminder, a 99497 is going to typically pay around $85, and 498 is going to typically pay around $75. Now, I would always recommend that you reference your most current CPT manual, but this is pretty good information available to you. So with advanced care planning, one of the things that really makes it unique is there's not a limit on how often it can be billed for. So different than an annual wellness visit where it's once a year, or transitional care management where it's one provider, one discharge. Advanced care planning really can be billed by just about any provider at almost any frequency. There really is no limit to the provider type or the frequency. The one key limit, though, is it does have to be a face-to-face visit. So you're not able to do advanced care planning as a telephone or as a telemedicine visit. So a couple other kind of final billing insights for you. Educate your patients that they may have a copayment. You can perform an annual or advanced care planning just about anywhere, but it's always good to know that you may have a copayment. Advanced care planning can be billed at the same time as a surgical global period, a transitional care management global period, or a CCM global period. This is really a code that CMS is promoting as a way to avoid unnecessary end-of-life costs, as well as unnecessary stress and care later in a person's life. And if an annual wellness visit and advanced care planning are performed together, there is no copayment for the patient. And both of those codes will be fully reimbursed by Medicare. Advanced care planning can be billed by a physician, a mid-level provider, or the other staff that might work under direct supervision of the physician that are typically involved in co-treating a patient. And consent is required because it's a voluntary service, and we want to make sure that, especially since the patient may have a copayment, that they're open to the conversation, that it's not something that we're forcing on them. This is meant to be a valuable kind of hopefully stress relieving in the long run conversation, but we want to make sure that we're not forcing it on the patient, and it always is good to get consent for treatment care scenarios. So now we have a couple scenarios for different ways advanced care planning might be used or might be seen. These are going to build off Mr. M, where he has class 3 heart failure. His functional status is a little bit limited, and he's going to see a cardiologist who spends about 35 minutes discussing end-of-life care options. Patient really kind of wants to make sure that we're going after all aggressive measures and wants to make sure that everything is documented. So that cardiologist, who spent 35 minutes with the patient, is able to bill for both his 99214, his E&M code for the visit, as well as a 99497, which is that 16 to 45 minute visit. Now Mr. M gets just a little bit worse, and a year later he ends up in the ICU. His primary care provider, who's a nurse practitioner, is brought in to help with some extra medical decision making. Really want to make sure that those primary care providers are as involved as possible with the care decision making. So that nurse practitioner is now involved in a 47-minute discussion with the patient's wife and the intensivist, who is the ICU provider, related to what should happen next with the patient. Now that nurse practitioner, having rounded with the patient or supported that care, is able to bill for the extra codes. So they're able to bill for both the 99497, which was the first 30 minutes, and then because it was a 47-minute discussion and we crossed that 46-minute threshold, she can actually bill for the 99498 as well. Now an intensivist is not able to bill for this in addition to his typical intensivist critical care code that he would be billing. So in this case, it's just the mid-level or the nurse practitioner primary care provider that's going to be billing for it. Mr. M is going to continue to struggle a little bit. So he goes home, he lives with his wife, and we want the best for him, but he is maybe not doing as well as we hoped. He ends up wanting to go back to the doctor to discuss this with his primary care provider, but the primary care provider is a little bit busy. So the doctor recommends that the patient talk to a social worker who's right there in the office. Social worker spends about 35 minutes discussing and kind of modifying the patient's resuscitation efforts, and they decide that they're going to avoid some of those highest levels of care. Now, since the social worker works under direct supervision of the physician, they're able to bill that as kind of within the scope, so they're able to bill the 99497 even though the physician didn't actually treat the patient. And for our fourth scenario, this is one where Mr. M is starting to really kind of go downhill, and he's developing sepsis from this Foley catheter, and he's requiring mechanical ventilation. So at this point now there's multiple care team members involved, and there ends up being a 30-minute discussion between the cardiologist and the patient's family related to end-of-life care, and an 80-minute discussion between the primary care team and the patient. So because of those two different conversations, the primary care provider is able to bill for both the 99497 and two 99498s, so one of the $85 codes and two of the $75 codes. And the cardiologist who was treating the patient, who did that 30-minute conversation, is able to bill for one of those 99497s. Now, from an ACO perspective, I believe that advanced care planning will help to reduce potentially unnecessary utilization and drive down cost. The more important thing, though, is by improving end-of-life planning, we can improve communication, reduce anxiety, and reduce that stress associated with unnecessary care. Now, as you're looking to ramp up or possibly start your advanced care planning program, I would first recommend adding advanced care planning to your annual wellness visit template. I would also look to find a way to incorporate some sort of a timer or validate that you're discussing at least 16 minutes worth of medical care. I would educate your staff on the importance of end-of-life care. That end-of-life care decision-making often has a little bit of a stigma associated with it that we need to kind of avoid as much as possible. And coaching the patient when they are at their most vulnerable, or discussing when they may be at their most vulnerable, is important. I would always recommend not focusing just on patients that are at the end of their life. While those are people that are candidates for advanced care planning, they shouldn't be the only ones. And really look at it as a way to improve end-of-life planning at other visits as well. This is a conversation that is there for the right opportunity. So looking for those cues for when it is the right opportunity to have the discussion is always key to being successful. As a tip to a provider, I would always say, do the first one. Tip to a manager, make sure we're billing for the first one and make sure that we're getting paid. And then once you feel comfortable with it, do more of them. This is the right thing to do for the patient. Thank you for your time. If you have any questions, please reach out by phone or email. I'm happy to help. Have a great rest of your day.